Dear chairpersons, dear colleagues, it's an honor for me to present at this excellent meeting on long-term risk of infections and cancer with DMT for NMOSD. My name is Clemens Warnke. I work at the University Hospital in Cologne, Germany, and here are my disclosures. The contents of this talk. As this is the first talk on NMOSD, I will briefly introduce the disease and the definition of the disease, to then come to the current DMT options, and then I will address the risk of infections and cancer with a focus on the long-term risks, and then provide you with a take-home message for your daily practice. As most of you will know, the full name is neuromyelitis optica spectrum diseases, and diseases means that's more than one disease. There are the larger group of patients defined by the detection of AQP4 IgG antibodies. So IgG class 1 antibodies directed towards the aquaporin 4 aqua channel, and you find them in around 75%, whereas there's a group where you don't find these antibodies. It's the smaller group, and I will focus on the AQP4 IgG positive patients because those are the patients for which we have approved therapy nowadays. Just briefly, if you detect the antibodies, the diagnosis can easily be made by one clinical core characteristic. Out of 6, you need to find one core clinical characteristic, and the first 3 are the most frequently seen characteristics I will briefly introduce. Just to remind you that NMOSD is a very severe disease that gives you, with a relapse, often disability from which the patient does not recover. So the aim of any treatment is to prevent relapses, as a progressive course is rarely seen in these patients. But if you have a relapse, it often affects the optic nerve, as shown here, and its extensive lesions that also reach the proximal parts of the optic nerve close to the chiasma, as shown here. And if it is acute myelitis, it's in many cases longitudinally extensive transverse myelitis, so it extends over more than 3 segments, again, as you can see here. And there's one other typical syndrome called aria postrema syndrome, where you get the damage to the central nervous system at the dorsal medulla, and patients suffer from untractable hiccups, nausea, vomiting, and sometimes the diagnosis is missed if you're not aware of this syndrome. But what is the pathogenesis of this disease? It's an autoimmune disease because we can find in the IgG positive patients, you find and detect antibodies that are pathogenic. So they do attack the aquaporin 4 expressed on the feet of the astrocytes. So you get destruction of the astrocytes either by complement-mediated cell lysis or by chemotaxis, again complement-mediated, that attracts then other players of the innate immune system, and you get this damage as I showed you before. And of course, these antibodies are produced in the end from the B cell lineage, so you can also interfere with all the mechanisms that finally lead to the production of AQP4 IgG antibodies in the subgroup of positive patients. And you can do this either starting at the end of this pathogenic cascade by complement inhibitors, such as Eculizumab, or you can interfere with IL-6 receptor and the pathways that enhance the antibody production, in particular by plasmablasts, or you can interfere with the B cell lineage and deplete B cells, and also plasmablasts and plasma cells are depleted by this anti-CD19 antibody Inebilizumab. As you can see here, in just a few years ago, we didn't have any approved therapy. So we used to treat the patients with classic immunosuppressive treatment, or rituximab or tocilizumab with an off-label use. But in 2019, approved therapies came on the market with the 3 drugs I just introduced. So the complement inhibitor Eculizumab, the CD19 depleting agent Inebilizumab, and the IL-6 receptor blocker Satralizumab. And my talk now is not on the efficacy, which has been nicely shown in the studies, but it is on the possible risk of infections and cancer in the long-term run. And I want to stress here, very in the beginning, we will have another talk, a Lancet lecture tomorrow. I'm happy to listen to myself, where we will talk about the efficacy shown in the clinical trials. I cannot focus this here, but we'll straight away go to the possible risks of interfering with the different immune compartments as shown on this slide. So I start with the complement inhibitor Eculizumab. It was studied for NMOSD in this clinical trial, published in the New England Journal of Medicine in 2019, where the efficacy was nicely shown. And as you can see from this slide, it's less than 100 patients that were studied here. So our data on long-term safety is very limited in this indication. And what is also important, the patients age 44 years roundabout, so it's middle-aged population. It's important for the possible risks of infections and cancer. And if you look at the adverse events that occurred, they were similarly distributed among patients treated with Eculizumab and placebo. And also, if you look at severe complications, it was again equally distributed. But there occurred 1 death in the Eculizumab group, and it was an infectious complication. It was a pleural effusion the patient died from, and one could detect 2 different bacteria, in particular Streptococcus intermedius. But the patient had a history of pulmonary disease, so this prior disease probably put the patient at higher risk, but it shows that infectious complications might play a role in the long-term safety of the drug. And this is supported also by looking at the adverse events that occurred. So upper respiratory tract infection were more often seen in patients treated with Eculizumab as compared to placebo. Yeah, but less than 100 patients and a short study duration. What do we learn on long-term risks? We should also look at the long-term extension studies of these trials. And what we see here is a similar rate of upper respiratory tract infections also during the longer course of the treatment, but no new aspects really appeared here. If we talk about long-term risks and also talk about malignancy, we need more data, so we don't have this in the NMOSD population treated with Eculizumab. But the treatment is used also in other indications, and there we have more than 10 years of pharmacovigilance analysis data available. So this data derives from the pharmacovigilance database of the marketing authorization holder of the drug, and it was published in 2019. And as you can see here, the population of patients with PNH and aHUS, which is diseases that are driven also by the complement system and the defect here, the population who was of the same age overall. And what you could see during the years of treatment was that bacterial infection would appear, and this is an accepted risk that you see in particular Neisseria meningitidis infections with the treatment of complement inhibitors. But what is seen in the graphic side is that the rate of occurrence of this infection over the years declined. And this is due most likely to higher vigilance and also to mandatory vaccination against Neisseria meningitidis already prior to starting the treatment. So this is an important long-term risk, and we need to make sure that our patients are vaccinated. But also other bacterial infections can occur, as shown here, and also tuberculosis. So you should screen for latent tuberculosis prior to start. And there might also be a risk of fungal infections with Aspergillus or Candida, as shown below. What about cancer risks? This is not NMOSD. The other diseases are driven, as I said, by defects in the complement system. So they might pose the patients at higher risk of malignancy due to the disease themselves. So looking at this table, it's not really conclusive for our NMOSD population, but probably we should be aware that hematological tumors could possibly occur, or that there could be a high risk of skin tumors. I think we should monitor this over the next years and decades. So to summarize for Eculizumab, the most common risks are upper respiratory tract infections and meningococcal infections. Vaccination is mandatory. And also atypical infections may occur, also fungi infections. And we should look at our patients, monitor them also for malignant melanoma or diseases of the hematological system. With this, I come to the next drug, Satralizumab, interfering with the IL-6 receptor and thereby reducing the production. This is one part of the mode of action, production of AQP4 IgG, and thereby also showing very promising results in the studies relevant for approval of the drug. And these two studies were published in Lancet Neurology and in the New England Journal of Medicine. And again, if you look at the total numbers of patients with NMOSD treated with Satralizumab, it's again 104, a very limited number, and the conclusions we can draw are limited as well. So we see serious adverse events, but they are equally distributed again between the placebo and the Satralizumab group, and the same is true for infection rates and serious infections. So no unexpected signs here, but if something occurs, it's common infections such as urinary tract infections and upper respiratory tract infections. Looking at malignancies, 3 types of malignancies were observed in patients. 2 were in placebo, and 1 case of SCC occurred in the Satralizumab-treated patient. So certainly this is no data we can draw firm conclusions from, in particular with regard to malignancies from this smaller study. What we see is that leukopenia and neutropenia occurs more often in the Satralizumab group, showing that in the end there's an immunosuppressive mode of action of the drug, but there wasn't a clear link between the decrease in leukocyte counts and the occurrence of infections, but it's needed to monitor this throughout the therapy. So as I showed, the data is limited due to the lack of long-term post-marketing experience with Satralizumab, so it's worthwhile to look at another drug having a very similar mode of action, Tocilizumab, which is approved for RA, for rheumatoid arthritis. And I show you some post-marketing data here. It appears that serious infections occur more often during treatment with Tocilizumab, whereas the malignancy rate is not obviously increased. There's one specific finding, in particular in patients with prior history of diverticulitis. You see gastrointestinal perforations with Tocilizumab. So this is something you might want to ask your patients if there's this history, and then consider whether or not the patient is the right patient for IL-6 receptor blocking medication. And looking at the product information of Tocilizumab in the EU, infections are reported, and upper respiratory infections are very common. Other infections such as diverticulitis are rare, but it's important to note because they are potentially life-threatening. And we don't really have data on the risk of malignancy. So far, there's no signs that the risk is relevantly increased, but I think we should also monitor this for Satralizumab in the future. Now I come to the last drug I talk about today, which is Inebilizumab. Inebilizumab is an anti-CD19 antibody which depletes B cells, and compared to another drug most of you will know and which has been used off-label in this indication before, Rituximab, it depletes B cells also in addition to what is depleted by CD20, also plasmablasts and plasma cells are targeted. So we expect a more pronounced effect also on the IgG antibody production with this drug. And this is, of course, an interesting way of also targeting NMOSD, as I showed you, that in the end, NMOSD is an IgG anti-aquaporin 4 IgG antibody disease and causes, in the end, an astrocytopathy driven by the antibody. So it makes sense to deplete B cells producing these antibodies. And it was shown the efficacy, again, in a phase 2/3 clinical trial. And looking at the mean age of the patients, it's similar to what I've showed you for the other studies. And looking at the numbers, it's a slightly higher number of patients that were exposed to the CD19 antibody, 175. And what were the side effects of this treatment during the observational period of the study relevant for approval? It was urinary tract infections. So again, you see common bacterial infections with this treatment, and it appeared to be higher, the frequency as compared to placebo. And there were 2 deaths observed during the clinical trial. One was related to a severe NMOSD relapse and not considered related to the treatment. And another one, in the end, it couldn't be worked out what the reason was. The patient developed new MRI lesions, and it could have been either an atypical NMOSD relapse or PML or ADEM. These diseases were among the differential diagnosis, and it couldn't be ruled out. But in the end, a warning for PML was included in the product information. So this is a possible opportunistic infection, but it's not clear if it really was PML. Looking at IgG levels, total IgG levels do decline as was expected, and you see a continuous decline over time, and this might be linked also to a high rate of infectious complications over time. But this wasn't shown in the clinical study, and it might be worth to look at CD20 blocking agent in MS to see whether or not this could be of relevance. And if we look at Ocrelizumab targeting CD20, you see that in patients who have IgG levels below the lower limit of normal, the infection rate of serious infections increase. This was presented in 2019 at the ECTRIMS conference, and you can see if you have IgG levels below the lower limit of normal, the risk of serious infections increase. And you also see this with IgM levels below the lower limit of normal. And another aspect, what we also can learn from Ocrelizumab in MS is that the infection rates, in particular in older patients and more patients with higher grade of disability, what you had in the progressive MS population, the Oratorio trial, that the infection risk might increase over time. And going back now to Inebilizumab, fortunately, we don't see an increase in the infection rates over time yet. So this is first data from extension studies. And in the first 4 years, of course, in a rather small population, we don't see a higher incidence per person year of serious infections with the treatment of Inebilizumab. But still, with our experience from Ocrelizumab, I personally believe we should monitor this also for Inebilizumab. What about cancer? From the clinical study performed with Inebilizumab, we don't know anything about cancer and mutagenesis. So again, it might be worth looking at CD20 blocking agents and from Ocrelizumab. So far, we don't have signs of higher rates of malignancy overall. In the beginning, there was a concern of a higher rate of female breast cancer as compared to cohorts, for example, the Danish cohort or Swedish cohort. And but if you look over time, it seems that the rates are not consistently higher, and that this risk might have been due to the random occurrence of breast cancer early in the studies. So far we don't have a clear indication that B-cell targeting treatments pose the patients at higher risk of complications when it comes to malignancy. So what is the take-home message for today? What are the main risks for these approved therapies for NMOSD? With Eculizumab, you need to consider meningococcal infections and other serious infections, also atypical infections such as Aspergillus infections. For Satralizumab, also be aware that serious infections might occur, specifically diverticulitis might be something you would ask the patient prior to starting the treatment. And for Inebilizumab, we also know from anti-CD20 treatment that chronic hepatitis B can reoccur, and therefore be aware that during long-term treatment, chronic infections might reoccur. But in the end, what we have seen so far are more like common infections at higher rate, which can become serious, in particular if the IgG levels get low. So what to consider before you start the treatment? Do the vaccinations, in particular the vaccinations against the meningococcal infections. You usually need 2 different vaccines, and the vaccination should be done 14 days prior you start the treatment, or you need to do antibiotic prophylaxis. And of course, you should not administer the drug during active infection. This is also true, of course, for the other two compounds. Also for Satralizumab and Inebilizumab, you shouldn't start the treatment during active infection. And I personally do for all the active drugs with which I treat my MS or NMOSD patients, I do a screening for hepatitis B and TB. And you should, in particular, do this for Satralizumab and Inebilizumab. And during the treatment, of course, it's worth to be vigilant for the detection and diagnosis of infections and also for malignancies. However, so far, we haven't really seen signs that these drugs pose you at high risk of malignancy in the NMOSD indication. And for Satralizumab, you need to monitor neutrophil counts, in particular in the beginning of the treatment, whereas for Inebilizumab, you should monitor immunoglobulin levels throughout the treatment. And if you see higher rates of infectious complications, you might want to consider to also give IVIG to compensate for the decline. And with that, I come to an end of my talk, and I thank for your attendance. Thank you very much.